So before we get into transition, I thought it would be nice to discuss the meaning of transfer. So historically, the practice has been to transfer a child who has reached the age of 12 to 13 into adult care. And this is not a hard and fast rule, but because there are other conditions that afford us flexibility as to when to transition this child. And it depends on the disease complexity and after considering whether this child is developmentally, clinically, and psychosocially ready. It's important to distinguish what it means, what transfer versus transition means. So transfer should be considered an administrative event. The child turns 12, they're issued a letter, and they're asked to go to the adult clinic, right? Transition, on the other hand, is a more holistic, developmental, clinical, and psychosocial process that endeavors to equip the child to become independent at managing their condition in a stable format and a sustainable manner into early adulthood. Transition is therefore multidimensional. We must remember that adolescents experience several layers of transition, and often simultaneously, which adds to the instability of an already vulnerable life period. And so if transition is not properly managed, this leads to an improperly prepared child who has a very poor understanding of their illness and therefore adherence. They are at risk for being lost to follow-up, developing virological failure, and the consequences of that, such as recurrent opportunistic infections, advanced HIV disease, and hospitalization, ultimately culminating in increased morbidity, premature mortality, and potentially avoidable suffering all in all.